lymph node dissection, at least in India, because our cases are different. Little more aggressive tumors and very true 3+3 is relatively less common, unlike in in US or Caucasian population. So probably we end up doing extended PLND in most of the cases. So because of this controversial topic, I am not showing any graphs, no pictures, no statistics. So PLND, all of you know, at least those who are doing radical prostatectomy, is a standard procedure. At least for staging evaluation, there is no question about that. This is the best staging one can do. If you want to say nodes are positive or negative, the single best modality is PLND. Its therapeutic benefit is questionable. I will discuss a couple of articles where they showed that therapeutic benefit is there, particularly from Briganti series. Its role and extent remains debated. So objective of my talk is to review the current evidence guiding PLND indications and template extent. It is very important to do PLND because lymph nodal involvement is a critical prognostic factor in prostate cancer. That is going to tell us what kind of adjuvant strategies to be planned. Accurate nodal staging influences prognosis and adjuvant therapy decisions. The imaging alone is insufficient for micrometastasis, whether you go for any type of imaging. Even PSMA PET scan has its own limitations, so it cannot detect, no investigation can detect micrometastasis. So this PLND remains the gold standard, at least for staging evaluation. So it's definitely recommended in intermediate and high-risk prostate cancers. At the time of diagnosis, based on prostate biopsy, we may feel it is low-risk prostate cancer. We may omit sometimes, but when you do radical prostatectomy, sometimes it can be upgraded. 3+3 can be, even we have seen 3+5 in Indian patients. So based on these risk stratification tools, Briganti nomograms and Partin nomograms, Partin tables, the guidelines suggest, particularly EAU, if the PLND risk of lymph nodal involvement is more than 5%, you do PLND. NCCN says more than 2% risk. Anatomical templates, various definitions are there. Limited, standard, extended, and super extended. I will not go into the details of that. The rationale for extended PLND, particularly this is very specific for Indian patients, is recommended for staging in high-risk patients. Most of our patients are high-risk patients. It definitely improves detection of lymph nodal involvement compared to limited templates, because we don't know which is the first landing site. Around 78% of the cases, directly it goes up in the presacral nodes. Again, definition of presacral nodes is again difficult to define anatomically. Generally, it is medial to the internal iliac group of lymph nodes. It is, some people consider it as part of internal iliac group of lymph nodes. So removal of nodes in the internal iliac and presacral regions reduce the false negatives. Presacral is not that just in front of the sacrum. The impact of PLND on oncological outcome, this is very important. Though conflicting evidence on therapeutic benefit of PLND beyond staging, some retrospective data suggest improved biochemical recurrence-free survival. I would like to spend some time here. Briganti showed 892 cases from 2 different series. It's all retrospective data. In that, almost they have done extended lymphadenectomy for all 100% of the cases, where lymph nodal yield was at least 10 or more than 10 on each side. In their series, if 2 or less than 2 nodes were involved, 28% of them did not develop biochemical recurrence. Meaning to say, at 10 years, 28% were cured if 1 or 2 nodes are involved. They did not require any adjuvant therapy. So looking at, going by that article, we can assume that it has a therapeutic role, but it was not proven in any other meta-analysis or retrospective series. The extent of dissection we discussed, more than 10 nodes are required. Higher nodal yield may be associated with improved cancer-specific survival. But we have to think about morbidity and complications of PLND, increased operative time, blood loss. Definitely lymphocyte formation is slightly higher. Risk of nerve injury, thromboembolism, particularly when you are contemplating extraperitoneal approach, and infectious complications. Very rare to get lymphocytes infected, but we have seen that. And morbidity must be balanced with the potential clinical benefit. Of course, in India, even training, most of the trainees does PLND. That's one added advantage for doing this. The modern imaging, I mentioned about PSMA PET scan, even sentinel lymph node, ICG, using ICG or technetium scan, or even intraoperative PSMA scans are available. Even with this, it cannot replace the standard PLND. These are all evolving. So, Briganti nomograms, MSKCC nomograms guide PLND decision making, helps avoid unnecessary detection in low risk patients, which is to what extent we can adopt in Indian scenario, we don't know. It all incorporates PSA, Gleason score, clinical staging, and tumor volume, which is not accurate. Even the best MRI accuracy of staging is around 75 to 80%, not more than that. It generally underestimates particularly the volume of the disease. So, controversies in PLND, therapeutic role versus purely diagnostic staging, which is there already. Optimal extent of PLND, still no consensus. Ongoing debate on indications for intermediate risk is evolving. We have to just wait for the level 1 evidence. So, impact on adjuvant therapeutic decisions, nodal positivities guide initial ADT or plus or minus radiotherapy, depends on the doubling time and all those things. It definitely enhances tailored approach in multimodal treatment planning. It improves clinical trial satisfaction accuracy. Open versus laparoscopic versus robotic. Robotic is definitely robotic assisted PLND offers enhanced visualization and potentially reduce the morbidity. But after listening to the best talks by laparoscopic surgeons, it can be duplicated even by laparoscopy. These are the emerging concepts, personalized template based on molecular and imaging findings. Sentinel lymph node dissection is evolving. It is still investigational, and investigation with genomic classifiers to refine the patient selection, who should go for what kind of template, that is still evolving. So to conclude, PLND is critical for accurate staging. That is, there is no doubt about that in intermediate and high risk prostate cancer. Extended template recommended for optimal detection but carry higher morbidity. Therapeutic benefit is controversial. Trials would address that in future. Individualized patient approach is very crucial. The guidelines recommend where the risk of involvement is more than 5%, recommend extended lymphadenectomy. Multidisciplinary discussions are necessary for treatment planning. So until then, PLND remains cornerstone of nodal staging in radical prostatectomy. Extent should be tailored, balancing the benefit versus risks. So future integration of imaging molecular tools would personalize the PLND. Thank you. Any comments, questions, I'm happy to take. Yes, ma'am.
What will be the role of lymph node dissection? Of late, I see many people even opting for neoadjuvant hormone and started. Even one of you are also one of them. So what is the relevance of a lymph node dissection at that point of time? If you really look at a neoadjuvant, you operate after 3 months. What is the real staging advantage you are going to get it at that time?
I think I am qualified to talk about this because we have close to 200 patients of neoadjuvant for locally advanced prostate cancers. We presented in last AUA in San Antonio. So clinical staging versus pathological staging. We typically give 6 months of intense neoadjuvant hormone therapy for all locally advanced, clinically T3 disease or even N+ disease we have given. What clinically N+ disease may become pathologically N0. In bulky disease, in younger individuals we have done, in them, even after 6 months of Degarlix plus abiraterone plus Vicelone, they still nodes will be positive. So you have to risk stratify them differently. You may have to continue hormone therapy, probably give radiotherapy, and even the extent of radiotherapy we have discussed. We have couple of patients, we have extended the field of radiation to lower paratic nodes. If despite of giving hormone therapy, if nodes are positive, your template would be different for even radiotherapy. Does that answer your question, or you have any other comments? Of course. See, if you give neoadjuvant therapy, if pathological complete response is there, how are you going to evaluate the stage? There is no pathological staging at all. For the prostate, I am talking about for prostate. If pathological complete response is there, pathologists will say there is no evidence of disease. How are you going to prove? This is still evolving. This is not standard of care. This is still evolving. So we have to just wait for some time. Of course, trials are going on. So once the prospective data is available, probably the Proteus trial is ongoing. Clinical efficacy of...
How do you prove, saying that, okay, by doing this, we have proven a clinical efficacy in these patients? Because there is a variety of heterogeneous group of population with heterogeneous group of histopathological bandwidth and heterogeneous group of age groups, and the biological behavior of the disease is never the same in each 10 patients, each 10 out of 100.
Absolutely. That's
so
why...
in each case, how do you categorize them, saying that by giving this, we got an advantage?
There is some evidence. There is some evidence.
I don't know. I'm saying I'm still...
Preliminary evidence is there that, if time permits, I can discuss on that. I can answer his question.
No, I'm talking about how are you, to the point of pelvic lymph node dissection. Suppose the disease disappeared or there is no disease. Do you think that, how do you infer on it? There is two aspects of it. One is there was no disease, you treated it and you considered it pathologically negative also. There was a disease in the lymph node which treated it, possibly became pathologically negative after histopathology. How are you going to differentiate these two?
Yeah, there are two new parameters we need to understand in this scenario only, where after giving neoadjuvant therapy, one is minimal residual disease. When the bulky disease becomes less than 5%, again, how are you going to quantify that? But the cutoff is 5%. 5% is the total prostate volume, that is minimal residual disease, number one. And second is complete pathological response. These two put together in the series, limited series, is about 25 to 30%. What are the outcomes of this? If you have given 100 patients this intense neoadjuvant hormone therapy, 25 to 30% have achieved minimal residual disease and complete response. So all of them at 40 months, that is 3.5 years, did not develop biochemical recurrence. So only that parameter, positive response is there. They did not develop biochemical recurrence. Just because they did not develop biochemical recurrence, they did not go for any adjuvant therapy at 40 months. So 25 to 30% achieving this and they did not receive, any adjuvant therapy, that itself is a big thing. Where you are giving, lot of drugs and showing 3 months, 4 months survival, in that postponing hormone therapy and radiotherapy is a big parameter. And this will not come from medical oncologists or radiation oncologists, this will come only from surgeons.
Yeah, Raghunath, we also do the same thing. And there is many advantage of starting neoadjuvant in locally advanced disease. Few things we have mentioned. The few things are the patients probably are inoperable or there is a large tumor. There might be, you might injure the rectum. And by giving neoadjuvant hormonal treatment, the tumor decreases. So your operation becomes easier. Complication rates decreases. Margin positivity probably may not matter because you have already started with the locally advanced disease and you know that you will do the multimodality treatment. Lymph node dissection, you will remove as much lymph node as possible whether they show or not, because very beginning you know that these lymph nodes were positive because of the, may or may not be positive because of the locally advanced disease. So you will remove it. Now what he exactly said, that is the advantage. Now you follow this patient with the biochemical recurrence. You will see the biochemical recurrence comes after 2 years and 3 years. And most of the patient, if you don't do the biochemical recurrence, it starts coming 6 and 9 months. So you postpone the further treatment, and when the biochemical recurrence, then anyway we have decided this patient will have a multimodality treatment. So your operation becomes easier, complication is rate, some of the non-operable becomes operable. And the biggest advantage is locally advanced disease, you take away the local symptoms, like these patients may develop symptoms when they may require TURP or something in future. Now prostate is out, that part is taken care of, disease load has decreased. So there are many advantages and the final trial will show. So we also, when we see locally advanced disease, some infiltration in the rectum, seminal vesicles badly involved, we also give the local, and we have been doing for last 14 years, 2014. And we have also developed large series. But the problem is most of the patients were international, everybody's follow-up is not available. So, but
Sir,
those
I'm
patients
not
follow-up is
questioning.
available, there is very good
po-
procedure.
Sir, the point now, I'm not talking about whether to give neoadjuvant at all or not. That's not a point of contention.
How are you going to
here.
assess? That's his
No,
question.
that's my question is, you are thinking about doing a PLND in these patients. What is the assessment? You see, at one point of time, what is the assessment? Number one, if there is a single node, you are curing the disease. You may not need a medical support to management later, adjuvant management later. Number two, if there is no mats, possibly you are good dealing with a better disease and you are going to have a it's a assessment of the thing. Presently, you have given neoadjuvant for 6 months. What are we doing additionally by doing a lymph node dissection? You can as well do a PSA. What you are doing it?
But most
Why
of the
are we
time,
doing a lymph node dissection?
most of the time
additionally?
lymph nodes are still positive.
So, in which case, whether
you
doing
have,
it also
so you
is
have
of no.
removed them. You have removed them, at
No,
least
you
decrease
can
the load.
decide the adjuvant strategies based on whether it's positive or negative. You'll get an idea.
Well, I think we come back to the indications of radical prostatectomy. No, I think we are not. Suppose in this case, I think I'll go back to a large nodes in iliac. I'll do a neoadjuvant and do a lymphadenectomy. Am I indicated to do that? If I tell that in the exam, will I get passed?
No.
Do I?
See, this is not
No.
this is not an exam question. We are not talking about this. Is outside even clinical trials we are discussing. This is still evolving. And to answer Dr. Anant Kumar's question, sir.
Let us start the next topic, please.
Yeah. Just to answer, 1 minute.
Answer my question.
Yeah. So in our series, generally, historically, when you do radical prostatectomy for locally advanced disease, margin positivity is anywhere between 40 to 50%. After this neoadjuvant in our series is only 13%. But whether that margin negative status would translate to better outcomes, we just have to wait. Yes, yes.
Thank you.
Thank you.
Thank you. Thank you, sir. Thank you for the insightful talk and the comments. Now, Dr. Mallikarjun, sir, will present on how do I do laparoscopic radical
I've shown how to do.
anatomy
Yeah,
of
I think
for
we'll
lap.
change.
Can we take, sir? Can we take comments from Dr. Anand? Yeah, can sir? Yeah, we'll take comments from Ramalingam, sir.
Yeah, before Malik starts, I think let's touch both the theatres for a few minutes.
Sir, we are on both the theatre. I mean, Dr. Ramalingam is on. Dr. Ramalingam, sir? Hello. You're on to the auditorium. Yes, sir. Hello.
We have been watching you. What's your plan?
To mobilize the uterus away from the bladder, but it was so adherent. I left with the choice other than opening the bladder. So I just wanted to see where exactly the fistula. Just going inside the bladder.
No, this I can close. That's okay.
That's the area, supratrigonal. There's a guide wire coming through the urethra into the vagina. So that's it. Now I take a straight needle and then reflect the bladder wall so that you have a good space to excise. I got the needle straight. Okay, come in. Let me try to mobilize the uterus away from the bladder. So that's the next job. Trying to mobilize. Tell me once you get the straight needle.
Dr. Ramlingam, if you cut into the fistula now, you will be able to get hold of the posterior vaginal wall straight away. Why do you need to dissect this?